associated with various side effects, including bleeding, hypertension, colitis, infections, arthritis. The more sort of important side effect of arrhythmias include fibrillation, ventricular arrhythmias, and cases of sudden cardiac death. BCL2 inhibitors are associated with sarcopenias, and early on they are associated with high rates of severe hemorrhagic syndrome, which is now quite rare with the low rate with the escalated and post-ramp-up weekly glucose. Precision medicine dictates that when you prescribe patients with CLL these medications, you have to assess the risk factors, personalized therapy according to the risk factors, and then monitor for specific adverse events. The other aspect of the treatment is the use of concomitant medications. The use of anticoagulants and platelets increase the risk of bleeding with BTK inhibitors. The use of electron blockers and interfere with the absorption of the older formulation of acalabrutinib. And these drugs are extensively metabolized in the liver, so abusers and inhibitors of CYP3A4 are reported in risk patients in this disease. So how do we select choose therapy for patients? So we look at, as I said, disease factors, mutation status, 17p deletion, TP53 mutations. We look at patient factors, age, comorbidities, and preferences. And then you look at the treatment in terms of efficacy, adverse events, and concomitant medications. And here's a simplified approach trying to maybe personalize, individualize therapy for patients with symptomatic CLL and requiring therapy. After assessing fitness, comorbidities, patient choice, and preferences for mutated CLL with no 17p deletion or TP53 mutations, a big option here is BCL2 inhibitors and obinutuzumab for fixed duration 1 year of therapy. For unmutated IgHV with no deletion 17p or TP53 mutations, the combination of BTK inhibitors and BCL2 inhibitors seems to be the most effective therapy in this subset of disease. Patients with deletion 17p, as you've seen with all of these therapies, they actually relapse once you stop these fixed duration therapy. So the option here or standard of care, recommendation is to use continuous therapy with BTK inhibitors. I wish it was that simple. So this is easy and straightforward, but it's not. So it is more complicated. Not all TP53 mutations are the same. The type of mutation you have, the site of the mutation, the domain where the mutation happens, the variant allele frequency are all important, and actually you have different risks for progression and survival. The finding of complex karyotype mutations with CLL, besides all of these other findings, is highly important, and it is predictive and prognostic. And the more sort of karyotypical abnormalities, the higher the risk. There's something now called highly complex karyotype with more than 5 abnormalities. And if you combine this with TP53 mutations, the number of abnormalities actually also dictates the prognosis in patients with TP53 and 17p mutations. There is also something now called borderline mutated CLL. Sorry, this is a mistake. It's 2 to 3% difference in the sequence of the gene of the globulin heavy chain variable region from other cells as well. And these patients actually tend to have a worse prognosis similar to that of unmutated. There is now there are a subset of CLL, about 30 to 40% of CLL patients who have almost identical sequences in the variable region of the heavy chain and light chain. And these are called serotype BCR B7 receptor subsets. There are different subsets that are described, and of interest subset 2, which can occur in mutated CLL, which is traditionally thought of as low risk. This actually is an aggressive form of disease and tends to make this mutated CLL more aggressive and poor prognosis. Notch1 signaling mutations or Notch1 mutations are also being described to be prognostic. There are more than 2,000 genetic abnormalities that are being described in CLL, and these are some of the examples of the pathways that are involved. But out of these, Notch1 seems to be important because it's actually predominantly affecting that mutated CLL, which is traditionally, as I said, thought to be acute prognostic disease. So it's not all about the gene, it's also about epigenetics, about transcriptomics, proteomics, and metabolomics. And this is just a sample of what is now described in the literature and reported findings of all of these multi-omic studies in CLL correlating with response to therapy or without. There are other considerations as well, the microenvironment where these cells are surviving or living in, and as well as the macroenvironment of the patient where these cells are circulating or surviving and proliferating, and as well as the environmental influences. And it's not a static process. Once you start therapy, select therapy for CLL patients or any patients, you have to monitor these. So there's something called precision monitoring, and we now have tools to actually precisely measure patients' response to therapy through the detection of minimum residual disease, either by flow cytometry or next generation sequencing. The ERIC has now standardized flow cytometry for CLL, and they're working on standardizing NGS. We have a recommendation for testing for 7BP and TP53 diseases. What this does is allows us actually to do what we call an MRD guided therapy instead of giving these patients continuous therapy with BTK inhibitors, exposing them to side effects and toxicities. There's more sensitive techniques that include circulating tumor DNA, and this is probably more sensitive than just flow cytometry. Precision monitoring in CLL and other disorders includes looking for resistance in patients who are not responding through the detection of mutations, and as you all are aware of, patients who continue suffering will tend to develop some mutations, and CLL patients develop mutations in the BTK molecule and PLC gamma, as well the most common, which is C481S, which renders these cells resistant to ibrutinib, A-type protein, and there's a wide gamut of these that are being actually described and reported. The same can be said about BCL2 because beneath the class there are some mutations that actually make the disease resistant as well. So this is all becoming so complicated. I suggest we maybe start using AI and machine learning or deep learning neural networks because it's very complex. And with this, I'd like to draw your attention to a paper we actually published a couple of years ago from a group in the region, a systematic review on sort of the application of machine learning in CLL, predominantly in diagnosis. And a more recent paper from Spain looking at machine learning and multi-omics in CLL. So precision medicine faces some challenges. These include standardization of these techniques. Translating all of this into clinical practice is not going to be easy. These testing methods are not widely available. And the most important aspect here is that the access to novel agents, novel treatment therapies, is not actually widely available. There's no point of doing this if we don't have access to one of these novel medications. But we have to continue looking at evidence-based medicine, real-world evidence, and more importantly, the value that these actually add to our practice through value-based medicine. This can only be done through collaboration between different groups. So in summary, maybe just 1 minute or so, how does this inform our practice, all of this review and discussion? And I'll say that at the end of my summary, but how does this inform our research in the region? I think we can actually work together looking at multi-omics in CLL because we have the expertise and we have the infrastructure to actually do this in the region. And maybe look at why our patients are younger, and maybe the perception that our patients actually behave more aggressively than patients in what's reported in the literature. And maybe we could actually do something more new and novel, looking at a deep sort of study of immunomics in CLL. It's very fascinating to see these malignant cells circulating in the peripheral blood where you have T cells and natural killer cells, and they are actually, these cells are surviving. So in summary, I believe CLL should be the poster child for precision medicine. There's immensely to directing the disease, patients, and available medications. Precision medicine in CLL starts with diagnosis, right diagnosis, right time, giving the right treatment to the right patients and looking at different factors from the patient's perspective and treatment perspective. For now, we look at IGHV mutation status and 17p deletion and TP53 mutations to maybe decide on what to choose from these BTK inhibitors or BCL2 inhibitors or a combination of these. But very soon we'll be incorporating border-mutated CNN, highly complex karyotype, TP53, variability frequency, BCR stereotype subsets, notch-1 and other things. And I believe in the near future will be depending on multi-omics-based AI machine learning assisted individual treatment. Just a glimpse in the near future. You cannot be more precise than this. There's now a report of mutation-specific CAR T cell therapy targeting a specific subset of highest CLL expressing a point mutation in the light chain variable digit 3 and showing that this is actually highly effective. So I thank you for your attention and I apologize for taking maybe a couple of minutes beyond my time. But I want just to remind you that all of this discussion should not divert our focus from the most important thing in positive medicine, which is the patient. It is far more important to actually know the patient who are dealing with, who has the disease, than the disease that the patient has. Thank you.
Thanks, Mr. Khalid, for excellent presentation. Actually, you did a question and discussion. So it's my pleasure actually to use Mr. Richard here to see that actually it's consultant in clinical child hospital and clinical senior lecturer and cancer genetics in the department of clinical and clinical genetics at King's College London. And his work response and acute myeloid leukemia. And this presentation is going to be about application of modern genomic assay and therapy.
Thanks so much for having me, and thanks for the invitation. So my talk is going to be about AML. This year is now 20 years since I've been a hematologist, and I'd like to reflect during my presentation about the huge changes during that period in the way that we diagnose and treat our patients and their outcomes. So this was the situation when I started as a hematologist in around 2005. The diagnosis of AML was made purely based on morphology, that if the patient had 20% myeloblasts, they could be diagnosed with AML. And there was really only one treatment available for patients who were treated with curative, which was DA 3+7. And a limited panel of diagnostics would be sent, but none of this would really influence the upfront treatment of these patients. So the cytogenetics and molecular results would take several weeks to return, and this was fine because there was only really one upfront treatment. And then the patient's response was assessed, again, purely by morphology alone. And if there are less than 5% blasts and the blood counts have recovered, the patient was labeled as being in remission. And post-remission therapy depended really only on the cytogenetics and then a very limited panel of molecular testing. At that time, only FLT3 and NPM1. This information was used to assign the patient to either a transplant or consolidation schedule. So with the explosion in sequencing technology, coupled with the great advances in understanding the genomics of AML, you can see that the situation is now entirely different in 2025. We now recognize that AML really describes many different biological entities. Some of these, listed in the top box, are sufficient to diagnose AML even in the absence of 20% blasts. All of these have different biology, different response to treatment, most obviously for the targeted inhibitors such as FLT3, IDH, and menin inhibitors, but actually it's becoming increasingly clear that these different biological disease subtypes respond differently to non-specific standard therapies. So just to give a couple of examples of this, the response to gemtuzumab appears to be highly dependent on cytogenetics, but the biggest responses on the left seen in those patients with core binding factor translocations and version 16-CD821. A second and more recent example using some data from our group is looking at the chemotherapy background. So this is for patients who have FLT3 NPM1 mutated AML. And you can see that their overall survival is dramatically improved by intensifying the chemotherapy backbone using the flat schedule, a difference that is not seen in most of the other biological studies. So the genomics now, as of 2025, allow us to make diagnosis of AML in most cases with less than 20% blast. They allow appropriate therapy selection, and one thing I'll go into some detail is they provide targets for highly sensitive and highly specific molecular monitoring, which can further be used to refine treatment. I'm going to illustrate this with a couple of real cases that I've treated in our hospital within the last year or so. So the first case I'm going to discuss is a 34-year-old female. She had no prior medical history, was previously completely healthy, and she presented with a short illness of about 4 to 6 weeks of unspecific symptoms. She presented with pancytopenia and blasts were flagged on her peripheral blood. She went on to have a bone marrow aspirate, and the morphology is shown here. You can see that there's clear dysplasia in all lineages. You can see that there's an increase in blasts, and actually on morphology the blast count was approximately 10%. And here is the histopathology. So this is a CD34. You can see this is only staining endothelial cells and then blasts. But on the other hand, CD117 is staining again approximately 10% in children versus. So thinking about how this patient would have been diagnosed and treated in 2005, the diagnosis would have been assigned for MDS with excess blast 1. The patient would have received single-agent azacitidine and would have been taken to transplant if eligible. Moving on to today, we cannot currently assign a diagnosis for this patient based on the information that I've given you, and in order to properly assign a diagnosis, we need to wait for genomic testing. So clearly that implies that there's a need for rapid versions of genomic testing so we can appropriately diagnose and treat patients. So here are the genomics for this particular patient. A cytogenetic showed a normal karyotype, and the deletion panel was normal. And a molecular study showed that she had mutations in NPM1, FLT3, and WT1. So the diagnosis today would be completely different. This patient would be diagnosed with intermediate risk AML, and in our current protocol would be assigned to treatment with 3+7+, which is about classified story for 3 years. In addition, the NPM1 mutation provides a nearly ideal target for sensitive monitoring of disease. So there's a few reasons why this is an ideal target for monitoring this patient. So the first one is we never see NPM1 mutations in healthy individuals or in clonal hematopoiesis. And this is now based on the study of many thousands of individuals and is in contrast to many AML-associated mutations. Although patients with NPM-mutated AML can relapse with wild-type NPM1, this is very uncommon and it's seen in less than 5% of patients. NPM1 mutations are shown in the left-hand panel are always insertion mutations and usually at 4 bases, meaning that they can be very sensitively and specifically amplified by both PCR and next-generation sequencing-based techniques. And finally, as you can see from the right-hand panel, NPM-missing transcripts are very highly expressed in AML, meaning that RNA-based assays can provide very high sensitivity of approximately 10 to the 5 to 10 to the 6. So this affects, again, the way we assess response in these patients. So in addition to the morphological assessment, which in this patient's case showed less than 5% blast with blood count indicating morphological remission, we now assess the NPM1 mutant transcripts. And you can see that on the right panel, in the top of the blood, in the bottom of the bone marrow. And you can see after this patient's induction therapy, she has achieved MRD negativity in the blood, and she's achieved 5 log reduction in transcripts in the bone marrow. We know from many different cooperative group studies that MRD clearance in these patients at early time points is strongly associated with outcome. And in our hands, in the bottom left-hand panel, you can see the patients who were MRD negative in the blood after their second induction course had an extremely good overall survival, and is contrasted with 3-year survival of only 24% of those patients with persistent MRD in the blood at that time point. And moreover, we recently were able to show, by combining data from two of our most recent protocols, that it is only the patients that had MRD positivity in the blood at this time point who benefited from transplant, which you can see in the left-hand panel. Those patients derive a huge overall survival benefit from transplant with a hazard ratio of death of 0.39, and there's no benefit, overall survival benefit, in those testing MRD negative on the right-hand panel. So this information will directly influence the way we manage this patient. She went on to have consolidation chemotherapy and did not receive the transplant of first remission. However, despite there being no overall survival benefit for this particular patient from transplant of first remission, we know that there is still a non-trivial relapse risk. And if you recall, this patient has some co-mutations involving both FLT3 and WT1. Both of those are associated with increased relapse risk, even in patients achieving MRD negativity. So she went on to receive very careful sequential MRD monitoring, and we made sure that stem cell donors were available in the event that a transplant was required. And here I'm showing the sequential molecular MRD assessments. And if you look at the bottom panel, you can see that the patient achieved MRD negativity in the bone marrow at the end of treatment and remained negative on the first assessment. But then you can see at approximately 1 year from diagnosis, the MRD has converted back to being positive again. So we would never take any action based on the results of one of these tests, because the corollary of very high sensitivity is a vulnerability to false positive results. We therefore immediately repeated the bone marrow for this patient. And you can see that the second sample is again positive. There's been an increase in transcript levels, and this patient is now able to be diagnosed with MRD relapse according to the criteria from the European Leukemia Network. So this condition of MRD relapse has only recently been defined and identified, and it's a very interesting clinical situation because we know with very high certainty that this patient is going to progress to fibrillation if not treated. But at the present time, the patient is very well with normal blood counts. So at the moment, work to establish optimal treatments for this particular situation are fairly preliminary. To date, we have only one published prospective study recording outcomes in this situation, and this is the VALDUC study, which was led by Andrew Way and colleagues at Melbourne. In this study, patients with MRD relapse were treated with a combination of venetoclax cytarabine. So what you can see is that a number of patients with MRD relapse subsequently progressed to hematological relapse on the time that the second bone marrow was performed to confirm the MRD status. However, these patients were still able to be enrolled in the protocol. From the middle panel, you can see that the patients who were treated at the time of MRD relapse had a very high response rate to this combination in terms of re-achievement of MRD negativity, with more than half of patients becoming MRD negative after 4 cycles of this non-intensive therapy. And the overall survival of the whole cohort was 63% at 2 years, which is rather good for relapse AML. Based on these small numbers, it was noted that patients with NPM-mutated AML appear to do particularly well with this strategy. And we were able to confirm this in a retrospective multi-centre study from a number of hospitals across Europe, in which we tracked results of 79 patients receiving venetoclax-based therapy for MRD relapse. You can see that in all patients, the response rate was rather high, with 71% of patients re-achieving MRD negativity. However, there was a clear difference between patients with and without FLT3 mutations. And for patients without FLT3 mutation, you can see their response rate is nearly 80%. And in the bottom right panel, you can see that their overall survival at 2 years was almost 80%. However, significantly worse outcomes were noted in patients with FLT3 co-mutation. So what about the use of FLT3 inhibitors at the time of MRD relapse? So far, we don't have prospective data for this setting, but we do have fairly good retrospective data from this study from the UK. The response rate to this treatment is 60%, with 45% of patients re-achieving molecular complete remission. And their overall survival at 2 years is approximately 80% from starting therapy. And you'll remember that the overall survival for patients treated with single-agent FLT3 inhibitor gilteritinib in the setting of frank relapse was only 20%. So it appears that we may get much better results by treating patients that MRD relapse rather than waiting for them to progress to frank hematological relapse. However, this does need to be confirmed in the prospective study. One issue with this approach is that FLT3 mutations are notoriously unstable between diagnosis and relapse, and particularly in the setting of FLT3 inhibitor therapy used in upfront protocols. And for this reason, all patients being treated with frank relapse AML should be retested for FLT3 before FLT3 inhibitor-based salvage is considered. However, there's a technical problem doing this in the MRD relapse setting, and this is a result of the limited sensitivity of standard FLT3 mutation tests. So the standard FLT3 ITT mutation test that you will order on patients at diagnosis, and frank relapse is based on PCR. And because the ITT is an insertion mutation in a predictable part of the gene, PCR will produce 2 different size amplicons in patients with the ITT mutation. And then these are resolved using capillary electrophoresis. However, the limitation of this technique is sensitivity of approximately 1%, and the limited sensitivity results from the electrophoresis step rather than from the PCR step itself. To get around this, a number of other groups have looked at ways of identifying FLT3 ITT mutations with high sensitivity using next-generation sequencing. And this diagram shows how these assays work. So the same PCR as within the standard diagnostic FLT3 test is performed, and then the second PCR is performed to attach sequencing adapters. And then the amplicons then sequence at very high depth, usually to a depth of approximately 1 to 2 million reads. Then using custom bioinformatic protocols, the ITT can be identified, and typically down to a sensitivity of 0.01% or 1 in 10 to the 5. And as well as being highly prognostic, this assay also identifies patients which will likely respond to FLT3 inhibitor salvage. So what I've shown here is the current algorithm that we use in the UK for deciding how to treat patients at the time of MRD relapse. So the first step is to confirm MRD relapse and secondly, we test those samples using high sensitivity FLT3 assays, which are based on an NGS platform that I've described. For those patients that have a detectable FLT3 ITT, these are treated with salvage FLT3 inhibitor. And for those where this is negative, the patients are treated with venetoclax and low-dose therapy. In this patient, we were able to detect the FLT3 ITT mutation at a level close to the limit of detection of 1 in 10 to the -5. The patient therefore received gilteritinib as salvage, regaining MRD negativity, as you can see, after the first cycle, and was able to be transitioned to stem cell transplant. All of this happened while the patient remained well, with normal blood counts, and most of the treatment was delivered as an outpatient. The second case to briefly discuss is that shown here. And this patient was a 22-year-old male. He presented with a non-specifically unwell with fevers and sweats, and as part of his workup, he underwent a PET CT scan. The result of that are shown here, and you can see that there's intense uptake in the bone marrow and the mediastinal mass. Biopsies of the mediastinal mass and the bone marrow both showed heavy infiltration with blasts. However, the pathologist was unable to assign a lineage based on the immunohistochemistry. The patient had normal cytogenetics and fish panel and normal FLT3 NPM1. And there were no mutations on the regular standard next generation sequencing panel. So one thing we found extremely useful in this situation is to perform RNA sequencing panel to look for cytogenetic cryptic fusion genes. And these can be used for both diagnostically to inform treatment, as I'll show you here. So this patient underwent RNA sequencing, which revealed the cytogenetic cryptic KMT2A fusion, and the specific fusion was KMT2A-ENL. The real advantage of this technique is not only does it allow us now to assign a diagnosis and identify the appropriate treatment plan, but it identifies the fusion sequence at the exact base pair level. And this allows us to then design and apply molecular assays to specifically detect this patient's fusion transcripts. And the results of that are shown here. So what I've plotted are the fusion transcript normalized to the baseline level. You can see that this patient has a 4-log reduction in the MLL fusion transcripts post-induction therapy with hypernucleotide, then went on to have a transplant and became MRD negative. There are emerging data now showing that KMT2A fusion transcript detection is strongly associated with prognosis. For example, this study, which was a collaboration between our group and the Australian group, looking at outcomes of patients undergoing a transplant according to their KMT2A fusion transcript levels. And you can see that those patients who had detectable KMT2A fusion transcripts going into transplant, they had a very high rate of relapse, and most of those relapses occurred within the first 18 months. And clearly now this is of very great interest given the increasing availability of KMT2A targeted therapies, such as menin inhibitors. So to summarise the impact of genomics and the genomic revolution on the diagnosis and treatment of AML over the last 20 years, the impact has been to allow us to make the diagnosis of AML in specific cases that previously would not have been diagnosed as such, to sort of classify patients into distinct biological subtypes with different clinical behaviour, to refine risk stratification, assign appropriate treatment, but also to identify targets to sensitively track disease, which can then help us to define risk based on response to treatment. Thanks so much for your attention, and thanks again for the invitation to speak at this wonderful meeting.
Thank you. The next talk will be precision therapy for adolescents and young adults in AML, and it will be given by Dr. Al-Madinah from MD Anderson Cancer Center. Dr. Al-Madinah is known to us. He is the chairman of the leukemia department at the University of Texas MD Anderson Cancer Center. And he authored multiple papers in leukemia, 2,000 peer-reviewed publications, with interest in AML and CML, and worked on different protocols that led to the approval of many chemotherapeutic agents. The presentation will be recorded, and then we'll have Dr. Katarzyna later in the Q&A session.
Of the novel targeted therapies that were. Thank you for the invitation. I'm going to update you on some of the novel targeted therapies that we're using in acute lymphocytic leukemia and which are changing the outcome of patients very rapidly. As you know, as of today, the standard of care is intensive chemotherapy in both childhood and adult ALL, and this intensive chemotherapy goes on for 3 years. This has met with a good success in childhood ALL with a cure rate of 80%, but in adult ALL, the potential 5-year survival remains at about 50%. and therefore there's a need to reduce the intensity and duration of chemotherapy and improve the outcome of adults with ALL. So what should we do in order to improve the outcome? I'm going to show you that in Philadelphia positive ALL, we have started using two targeted therapies, ponatinib, BCR-ABL kinase inhibitor, and blinatumomab, a CD19 bispecific T-cell engager with very good results. In PBALL, we have reduced the intensity and duration of chemotherapy, and we have incorporated blinatumomab and another CD22 antibody drug conjugate called inotuzumab. We're now using CAR T cells as consolidation for minimal residual disease instead of using them in active refractory relapse ALL. And we're tracking the residual disease by the NGS clonoSEQ for the immunoglobulin heavy chain rearrangement, which analyzes about 3 million cells and gives us a very accurate status of residual disease and need to change therapy as well as the duration of therapy. Let's start with Philadelphia positive ALL, where as of 2002, the outcome of these patients was fatal with intensive chemotherapy, and the few fortunate to have a potential donor had a cure rate with the transplant, which is about 35%. Over the years, things have changed with two inflection points. The first one was in 2000, when we started adding the BCR-ABL kinase inhibitors to intensive chemotherapy. And then the second inflection point was in 2017, when we started replacing all intensive chemotherapy with blinatumomab. The patients were living longer, so there were CNS relapses, and we increased the intrathecals from 8 to 12 and recently to 15. And now we rely on transplant only in the patients who have persistent disease by BCR or NGS MRD. This is the update of the hyper-CVAD ponatinib. So this is preceding the ER of non-chemotherapy. We treated 86 patients with chemotherapy ponatinib. Very few of the patients went to transplant, 20%. Almost all the patients achieved a complete molecular response. And for the first time, the 5-year survival was 75%. And on the right side, we could not define a specific benefit for allogeneic transplant, which is the blue curve, compared to the patients who were not transplanted. So the non-chemotherapy regimen had three rationales. The first one was that 3/4 of the patients who were relapsing with a T315I mutation. This was reported by Dr. Russolo, so this led to the change to ponatinib. The second change was that blinatumomab was better than intensive chemotherapy, reported in the middle by Dr. Rambaldi, so we replaced blinatumomab for the chemotherapy. And the third was that as patients were living longer, we started seeing CNS relapses. This is shown on the right side. And this is why we increased the intrathecals from 8 to 15 as of today. This is the regimen. Ponatinib is toxic, so we do not give it at 45, but only at 30 milligrams daily. And we start blinatumomab during the induction. And we give the blinatumomab for 4 courses. We give the ponatinib at a reduced dose in complete molecular response, 15 milligrams daily, for at least 5 years, and we give 15 intrathecals. So this shows that we can very quickly get 2/3 of the patients in a complete molecular response after 1 course of blinatumomab, and by NGS MRD, 90% of the patients become negative. Similar experience, so this is the results of our experience. So remember, ponatinib and blinatumomab are given simultaneously during the induction. Ponatinib 30 then reduced to 15, blinatumomab 5 courses, today 15 intrathecals. Of the 76 patients after a median follow-up of 2.5 years, only 2 required a transplant, and the 3-year survival is 88%, shown in blue on the right side. And we are having relapses, mostly patients with high white cell count. So in patients with a high white cell count over 70,000, we are introducing one course of high-dose methotrexate therapy. This is shown on this slide where we're reporting that about 15% of the patients present with a white cell count over 75,000. These are the patients who are relapsing in red, both CNS and systemic, and we're adding high-dose methotrexate RC back into those patients. The Italians reported on a similar experience, but they had two changes. One, they kept the ponatinib at 45 milligrams in the younger patients during the induction, and two, they started the blinatumomab in remission. They reported good results, as we did, with a CR rate of 98%, and with a short follow-up of about 1 year. The 1.5-year survival is 95%, but they are starting to see relapses as we did. And importantly, 40% of the patients are having to reduce the ponatinib dose because of liver, pancreatic, and cardiac problems. So 30 milligrams is probably better than 45 milligrams. On this slide, I summarize 4 studies that have reported on non-chemotherapy regimens. The second column is ours, 4-year survival, 88%, very few go to transplant. On the extreme right is what I just showed you, the Italian experience, where they are starting to rely less on transplant. And in the middle, the third column is the Italian experience with dasatinib blinatumomab, where they rely on transplant in 50% of the patients and had also a 4-year survival of 82%. One could say, well, we cannot continue the TKIs for a very long time indefinitely, so can we, like CML, stop the TKIs at a point in time? So we looked at 14 patients in our historical experience that stopped the TKI after the treatment because of severe toxicity like pleural effusion, arterial occlusive event, or pulmonary hypertension. And we were happily surprised that, in fact, most of the patients remain treatment-free remission, but essentially you should maintain a complete molecular response for 4 to 5 years. This is the blue curve on the right side, where the patients who were in a complete molecular response for 4 years or more were not relapsing once we stopped therapy. And this shows in red the survival of the non-chemotherapy regimen, ponatinib blinatumomab, compared to hyper-CVAD ponatinib in blue, hyper-CVAD dasatinib in green, so much better results. Next, we are going to discuss 3D ALL, where we're relying now on the 2 antibodies targeting CD19, blinatumomab, and CD22, inotuzumab, and now we're relying on the CAR T cells as a treatment for minimal residual disease. So the rationale was the randomized studies comparing blinatumomab and inotuzumab to standard of care chemotherapy. And we showed in those studies that both blinatumomab and inotuzumab were superior to standard of care intensive chemotherapy. But we could not cure too many patients. So we're paying a lot of money and not curing many patients if we use those drugs in the FDA approval indication. So at MD Anderson and the younger patients, we continued to use the hyper-CVAD, but we reduced it to 4 cycles. The second change was adding blinatumomab to sequence for 4 cycles. And the third change was to reduce the pump maintenance from 2.5 years to 1 year. And then later we added inotuzumab in a fractionated dose schedule in 4 of the 8 courses. So these are the results in the first 75 patients. CR rate 100%, NGS MRD negativity high. And for the first time, the estimated 4-year survival in our hands was about 90%, which is almost as good as the results of childhood ALL. In the middle, I show the red curve, which is with the addition of both blinatumomab and inotuzumab. And on the right side is the difference compared to the previous regimen not include either of these antibodies, so we're getting very good results. And on this slide, I summarized in the first 2 lines our experience, and then in the next 5 lines, the experience from Germany, France, and other places where adding blinatumomab to chemotherapy improves the early results. Also, last year in the New England Journal of Medicine, Dr. Litso reported on a study where patients were treated with 3 courses of chemotherapy, and then the patients who became MRD negative were randomized to either 4 more courses of blinatumomab or more chemotherapy. So of the total of the 488 patients, it's important to note that less than half became MRD negative, and these are the ones who were randomized. And the study did show an improvement of the 5-year survival from 55 to 85%. So this led the FDA to approve blinatumomab as frontline therapy in acute lymphocytic leukemia. But we have to do better because we are benefiting only half of the patients. So we have to move those targeted therapies more into the frontline regimen. 2 months ago in the New England Journal of Medicine and at the first ASH abstract, there was a pediatric study that was reported where children with standard SPLL were randomized to the chemotherapy or the addition of 2 courses of blinatumomab, and that study showed definitely an improvement in the 3-year disease-free survival from 88 to 96%. And this then established that blinatumomab should be used in ALL across all the age groups. But the question is whether we should use 1 course or 2 courses, 4 courses, or more. So I showed the same study where they did a subset analysis by the number of courses received. So this is the same 224 patients. On the left side is the difference in the survival. In the middle are patients who did not receive blina versus those who received 2 cycles. And on the right side is 2 cycles versus 4 cycles. So it appears that at least a minimum of 4 cycles of blinatumomab is needed. In patients with minimal residual disease, at the bottom on the right side, I showed that patients who are MRD positive have a 4-year survival of 20%. At MD Anderson, we added 5 courses of blinatumomab to 37 such patients, and we showed that 83% became MRD negative, and the 4-year survival improved from 20 to 60%. And on the right side, the fact that doing an allogeneic transplant after getting a negative status, MRD negative status, did not help the patients because of the mortality from the transplant. So this is where we're going to start using the CAR T cells. Let's now talk about older patients with ALL. So patients over the age of 60, where when you use the intensive chemotherapy, and this is from the SEER data, the estimated 5-year survival is less than 20%, at best 15%. So really those patients do not benefit much from intensive chemotherapy. What we did here is give them a mini CVD, so minimized chemotherapy. We added blinatumomab for the first 4 cycles in blue, and we added blinatumomab in sequence for 4 cycles. And we showed that there's almost a doubling of the survival, 5-year survival increasing from 20 to about 50%. So I think this is a very good regimen for older patients with ALL. And other groups have shown similar data by adding either blinatumomab or inotuzumab with high CR rates over 90% and estimated survival rates certainly in excess of 10%, ranging from 40 to 50%. Now, what do we do in B-cell ALL? This is a disease where we do not have yet targeted therapies, so we rely mostly still on the intensive chemotherapy with the addition of methotrexate, arabesartanate, and we recently added venetoclax to the regimen. We reported our experience in leukemia last year. In 145 patients, the CR rate is 90%, and the 5-year survival rate is 64%. But since we added the venetoclax, we noticed an improvement in the survival rate at 4 years, from about 60% to about 80%. So venetoclax has an important role in T-cell area. Now there are targeted therapies coming along, and this is the experience from China, where they used CAR T-cell targeting CD7 in 60 patients, and they reported that those CAR T-cells were able to induce a complete molecular response rate in 94%, and they resulted in a 2-year survival rate of 63%. So I think the CD7 CAR T-cells are coming soon to T-cell ALL therapy, and we are going to use them again in remission, in first remission, to consolidate therapy. Where then do we use allogeneic transplantation? We still transplant patients with KMT2A ALL, patients with precursor T-cell ALL, and patients with a complex karyotype more than 5 abnormalities, as well as patients who are Philadelphia-like with JAK mutations. So these are about 15% of the patients where still we need to do allogeneic transplantation in first complete remission. Now, what about ALL relapse? So again, historically, when you look at the studies from England and France, and about 1,000 patients who were in first relapse, even though you can get maybe 40 to 50% in complete remission with intensive chemotherapy, there is still a death sentence about these patients because the cure rate is only 7 to 8%. We use the same mini-CBD in Al-Madinah, in ALL salvage, and in 125 patients, the CR rate was 63%, the overall response rate was 83%, the 5-year survival increased to 40%. With the 2 antibodies, the 5-year survival is quite good. The estimated 3-year survival is about 3%. And again, no benefits from stem cell transplant, so we're going to try to use the CAR T cells in remission here. The last 2 discoveries are the following. The first one is we developed subcutaneous blinatumomab, and we showed that it is not only easier to deliver, but we can deliver 5 times the dose. And in patients with refractory relapse ALL, the subcutaneous blinatumomab given to 27 patients produced a marrow CR in 90% and MRD negativity in many of the patients. Importantly, the median survival is over a year compared to about 7 months with the historical data with the IV blinatumomab. And the same experience has continued to be positive in about 80 patients that we're going to report on at ASCO soon. Finally, I want to show you the results of what's called dose-dense mini-CBD in Al-Madinah. So this is where we give 6 courses of minimal chemotherapy. We give the inotuzumab in the first 4 courses, and then we tag the blinatumomab not in sequence, but starting on day 5 of each course for about 18 days for 6 cycles. In the first 22 patients that we treated in the refractory relapse setting, the overall response rate was 100%, and the 1-year survival was 90%. I show it on the right side, the dose dense in green, compared to mini-CBD inotuzumab in red, mini-CBD inotuzumab blinatumomab in blue. So we think that the dose dense mini-CBD is not only just condensed and easier to deliver, but could be more effective, and we're going to try to expand the experience and move it into the frontline setting. So in summary, in Philadelphia positive ALL, we're using less chemotherapy and transplant in favor of potent BCR-ABL kinase inhibitors and blinatumomab. In pre-ALL, we're using less chemotherapy for shorter durations, but adding inotuzumab and blinatumomab, and we're now monitoring patients with the clonoSEQ NGS to detect very little residual disease and implement changes of therapy, even if we find 2 or 5 leukemia cells in a million cells that we are analyzing. And finally, I showed the data with the subcutaneous blinatumomab as well as with the dose-dense mini-CBD inotuzumab blinatumomab. Thank you for your attention, and I hope I'll be able to join you for the discussion.
Next, I would like to invite Dr. Rihab Ahmedi to give the next presentation. Dr. Rihab is a consultant hematologist and BMT at Princess Oncology Center at King Abdulaziz University in Jeddah. And he will be giving a presentation about individualizing therapy and low-risk myelodysplastic syndrome, new evidence and option for your patients.
Thank you. Thank you very much for the introduction and the kind invitation. So we'll start with the definition of what is low risk MDS. So who are patients that are classified as low risk MDS? Majority of the trials have actually used the IPSS-R score, which is a relatively crude score based on number class, percentage, the karyotype of the patient, hemoglobin, and the platelet count, and the absolute neutrophil count. And based on that score, patients are stratified into multiple risk factors. And this is the stratification. It shows that it links patients into different risk groups. However, 94% of MDS patients will have mutation. And this has led to the publication in the English Journal of Medicine in 2022 of the IPSS molecular score. And the 3 common mutations in MDS are TET2, which is about 73% of MDS patients will have TET2 mutation, SF3 25 to 30%, and SF6 about 20%. So we have adverse mutations when they are present, they lead to worse prognosis. We have favorable mutations that lead to better prognosis, and with mutual mutations. And these are a list of the common mutations, and in an era of precision oncology, maybe we have to think again about how we stratify our MDS patients. And this has shown that 58% of the MDS patients will be classified based on the molecular score as a low risk, very low risk, and medium low risk patients. So the curves, as you see here, into 6 groups based on molecular studies. It follows a complex calculation method, which has shown that it stratifies our patients with very low risk, with no risk of AML transformation and death from MDS, very high risk of transformation and death from MDS. And this stratification, when you compare the IPSS molecular to the IPSS-R, you will find that IPSS molecular will upstage certain groups, like in here, some of the very low risk by IPSS-R will be stratified as a very high risk based on the molecular studies, and it will also downstage some of the patients. And this is very important when we are making trials in the future, that we stratify our patients appropriately so that we get the appropriate results. This is the Ritter set the trial. And this trial, the stratification was based on the ISSR score. And as you can see here, there were no high-risk ISSR in this trial. However, when you look at the patients using the ISS molecular, you'll find here that there were patients included in the trial. They were presumed to be low risk. However, by molecular studies, they are actually high risk, and it will be interesting to see the outcomes of these patients, whether they do as well as the other patients or not. This is the ISS molecular risk calculator, which you can find online and you can use to stratify your patients. So how do we manage the low-risk MDS patients who need treatment? Until now, there is no data to suggest that asymptomatic patients require any treatment. However, patients with anemia and symptomatic will require treatment, and those with thrombocytopenia also will require some form of treatment in leukemia. So what are our goals of care for low-risk MDS? We want to control their symptoms, we want to reduce or eliminate their transfusion needs, and we want to improve their quality of life and minimizing treatment-related toxicity. I want to reduce their risk of disease progression and improve their overall survival. So what would be used for symptomatic patients with anemia and thrombocytopenia, their equal level below 500? The gold standard of care is erythropoiesis-stimulating agents. There is all trials, for example, like this trial where darbepoetin was used against placebo, and this has shown that darbepoetin significantly improves the transfusion independence in this group of patients. Then we moved on to see whether we need to treat patients early with erythropoietin-stimulating agents. This European trial was randomizing patients between early use of erythropoiesis-stimulating agents versus late use, and we wanted to see whether this made any difference to the patient's outcome. And this was reported in the last ASH 2024, and this has shown that there is no difference in median time to red blood cell dependence between the two arms. There's a higher overall response rate and duration of response using the ESAs early, but there is no difference in progression-free survival and overall survival between the two groups. So there is no point in the conclusions, there is no point in using it early in MDS patients. The quality of life was similar between the two groups, the early users of ESA versus the late users of ESA. Patients with symptomatic anemia and thrombocytopenia with venous or SF71 mutation, this group of patients, new agents like luspatercept were used in this group. Luspatercept is a transforming growth factor beta stimulator, and transforming growth factor beta is an agent that we all have that is involved in cell control, proliferation, differentiation of the cells, and it will lead to the promotion of late-stage maturation of erythroid precursors. And the MEDALIST study was the first phase 3 study using luspatercept versus placebo in those patients with ring sideroblasts, and this has shown statistically significant improvement in transfusion independence compared to placebo. Then came the COMMAND study, which showed luspatercept in very low and intermediate risk MDS versus EPO alpha. However, an important point in this study is that 70% of patients had ring sideroblasts. So we know that luspatercept work very well for this group of patients, and in my opinion, the number of patients with ring sideroblasts was overrepresented compared to the other groups of MDS. So this study has shown that the primary endpoint was achieved, that luspatercept improved the outcomes of patients and transfusion independence compared to the patients, and also the target hemoglobin rising by 1.5 grams was higher in the luspatercept arm versus the EPO arm. And in 2024, ASH COMMAND long-term outcomes was published, and this has shown that at 12 weeks, 58% of patients, 76% of patients with luspatercept were transfusion independent versus 55%, statistically significantly better. Again, at 1 year, again, luspatercept was statistically better, 44% versus 27%, and at 1.5 years, 30% versus 13%. So, subgroup analysis of this command study in those patients with equal less than 200, 35% of patients on the luspatercept arm achieved transfusion independence versus only 15% in the equal arm. Patients with the SF3B mutation, 36% versus 14%, so almost more than double the improvement in luspatercept. The wild type SF3B, the improvement with luspatercept was less pronounced than those who are mutated, 21% versus 13%, and those who are invincible blast 32 versus 13, those without invincible blast 24 versus 16. The safety, there is no safety concern using luspatercept versus EPO, and the main side effects grade 3 are fatigue, anemia, back pain, nausea, headache, and they're minimal. In general, the rates of side effects has gone down with time. So this is a real world data of using luspatercept, and what this shows is that when you increase the dose of luspatercept from 1 to 1.33 to 1.7, as you increase, then you get more patients using less transfusion, even if they were transfusion dependent. So upping the dose is something that would be clinically beneficial. Patients with symptomatic anemia, no cytopenia, non-responsive to ESA or EPO, more than 500, and they're heavily transfusion dependent, are defined as more than 4 units over 8 weeks. There is this study of imetelstat, which is a telomerase enzymatic activity inhibitor. The telomerase enzymatic is a shortening end of chromosomes, and its function is to prevent loss of important genetic material. So this is how imetelstat works. It's a competitive inhibitor of telomerase enzymatic. This is a nice study, phase 3, of imetelstat versus placebo, and 2-to-1 randomization. And this has shown that using imetelstat improves the transfusion independence, 40% after 8 weeks of use, 28% at 24 weeks, and 80%. The dose benefit wore off with time, however, it still remained statistically better than placebo. Again, this is the hemoglobin of 1.5 increase using the medication, was statistically better using the imetelstat. However, patients who used the imetelstat, they used more platelets and they needed more growth factors, so it seems that it suppresses their bone marrow. There is no improvement in overall survival, so it's similar in the experimental group versus the placebo group. In terms of subgroup analysis, you will see that there is an improvement in all groups of patients, even patients who use prior use of luspatercept, prior use of lenalidomide, and prior use of azacitidine. Lenalidomide is an old agent that has been used in MDS for a long time, and this study has shown that it works even in those patients with non-5q deletion in low-risk patients, but it works better in 5q deleted patients at a dose of 10 milligrams. It is even better than 5 milligrams. However, there is increased toxicity with neutropenia, thrombocytopenia in the patients in whom we use lenalidomide. The Sinatra study, which was in low-risk MDS patients using lenalidomide 5 milligrams versus placebo, this has also confirmed the usefulness of lenalidomide in terms of transfusion dependency if lenalidomide was used versus placebo. Oral azacitidine, this trial was using oral azacitidine in low and intermediate risk MDS. They are still on the trial. It was using 2 doses, 200 versus 300, and both doses were effective, equally effective in fact. However, the toxicity with 300 was more, And for that reason, probably I would expect if they are going to do a phase 3 study, they will probably choose the 200 dose. A side effect profile, as I mentioned before, there's more toxicity with the 300, but there isn't more efficacy. The activin type 2 receptor is another TGF-beta receptor family, and it controls the growth and cell differentiation and homeostasis of cells. And the Ritacept medication was tested in a phase 2 study. It improves erythropoiesis and thrombopoiesis by its mechanism of action. And this study was a phase 2 study of 31 patients, and it produced some reasonable data. Overall response rates was 55% versus, obviously there is no control arm, but in the high transfusion patients, almost 50% of patients responded to the medication, which is a reasonably good response in patients with high transfusion burden, which was defined in this trial as having 4 red cell transfusion every 8 weeks. However, I have concern with this medication, and my concern is there were about 4% of patients died, and it was possibly related to the medication. The death was mainly due to heart rate failure, MI, and some deaths. There is a phase 3 study ongoing, and this phase 3 study might give us more clues about the toxicity and safety of this medication and its efficacy. So in my conclusion, long-term follow-up of the LAND study demonstrates more durable responses to luspatercept among all subset of patients, especially the SF3B1 and lymphocytoblasts. Predictors of durable RBC transfusion independence more than 1.5 years include that those with less transfusion burden tend to respond more, and those with lymphocytoblasts and SF3B and low serum people tend to have better responses than other groups. However, pharmacogenomic studies will be an important factor when considering using luspatercept in patients without the lymphocytoblast or SF3B mutations. The ESA treatments would still be considered as a standard of care in those with EPO levels less than 200 and no lymphocytoblast or SF3B mutations. Idelalistat retains clinical efficacy after luspatercept failure and beyond second line, and it is a useful agent to have for low-risk MDS patients. And idelalistat demonstrates encouraging activity, and a phase 3 randomized trial is being launched, and we await that study results. Thank you for listening.
Thank you, Dr. Yahya. I'd like to invite Dr. Samirov to give his second part of his serum talk, which will be about the precision serum therapy minimal effect or maximum tolerance.
Good afternoon again. So can I have this slides? Okay. So when we talk about precision medicine, we can say, concerning CNL, which is really, I would say, a modern progress still, just model for just the therapy, personalized therapy of the patients. As you know, indeed, the oral patients nowadays is very good. Is the oral kind of registry in which more than 1,500 patients have been enrolled. After 5 years, it is 88%. But what is even more surprising is that only a small percentage of these cases are dying because of similar causes, 30% approximately. So this is where the others are dying because of comorbidities or other factors, but not directly related to CNL. Indeed, the major cause of CNL is due to the progression. You see, among approximately 1,500 patients, we had forward progression. As you see in some cases, in a certain phase, this is still, I would say, for the we are acceptable because we have only 3 deaths. There's a plastic phase, which is inevitable. Indeed, the progression were 27 cases, and 2/3 of them died because of the disease. Just examining these cases died, we see that most of the progression occurred just within the first 2 years from the start of the therapy, and mainly in the so-called high-risk intermediate risk group. We will see that these together represent approximately 30% of the patients. Only the 3 cases out of 22 were in the lowest group, which is constituting approximately 60% of all the patients in that time because of SEDA. So if you have, I would say, patients in the low risk group, the probability what you have to do just to start the treatment with TKI and therapy, this is multiple generation TKIs, the problem certainly is not the most of these patients. There is another aspect that we are considering as overall survival is almost being solved, not totally, but almost. You will see that this is the original study, showing that patients were achieving a very deep molecular response, and that this continued with therapy after, say, 40% of them, after some numbers of years, are still in full remission without the need of actually medicating the TKI therapy. And this is these patients, according to our criteria, can be considered cured of the disease. And all the relapses were according to the relative time of the 6 months. I would say some of them even within 1 year, but after some period of time, very little relapses are occurring. So to achieve this goal of treatment remission, we need to achieve a very deep molecular response, which is considered MR4, which is the use of disease of 4 blocks with respect to the amount which are found in diagnosis of 4.5 blocks. And you will see that it's more easy to be achieved if we are using a second generation TKI than Al-Madinah, and we can estimate that over 5 years, approximately 30% of the patients are ready or meeting the criteria to try to stop the TKI therapy, but we have to wait for a long period of time if we are using Al-Madinah. But the percentage in which there is a successful discontinuation at the moment are still only a small percentage, maximum 25% of all the similar population that we are treating. So we have 2 main problems at the moment in similar therapy. The first one is just the treatment of the TKI-resistant patients who still remain at risk of progression, and the treatment is continuation, achieving cure, and all the side effects that we can have, of course, for all the patients who have to continue to get therapy because they are not, I would say, already cannot afford to stop. Precision medicine and patient-tailored medicine may help us solve this problem. Now we show some examples. Certainly we have to pinpoint for the patients who are at risk of progression, patients who will be at risk of progression. And this is defined by the NS4, by the cytogenetic analysis, and also by the NGS. The health testers, I would say that the score is very, very good, as I told you before, because 96% of the patients approximately are falling so low risk, and this represents 2/3 of the entire similar populations that they are observing. The overall survival at 5 years is definitely lower than the intermediate and the particularly in the highest group, but this altogether represents 1/3 of the similar patients. The risk is higher, of course, for the high risk group, which the overall survival after 5 years is 71%. But these are not linked to the similar to that, as we've seen before. but to other causes. So certainly there is a risk of progression associated with the biology of the disease that at the moment we are still in parallel. Certainly the cytogenetic abnormalities in addition, this is the constant may play an important role. This has been clearly demonstrated by the German group. You see here that both the diagnosis and also, of course, the treatment, if there is the appearance of an additional cytogenetic abnormality, this is associated with an inferior overall survival. But there is another point which is now emerging, that it does not involve, I would say, a pH clone, which is important just to be studied at a very early point before the generation of other symptoms that can finally lead to the blast crisis, is the normal hematopoiesis, not the residual normal hematopoiesis. This sometimes is not so normal because it's affected by other mutations, which are particularly well known as clones affecting some genes of the mild kinds of genes. So these are clonal contributing clone potential. Among them, certainly, one of the measures represented by the SLS1, and intervention is being concentrated at the moment on the research in Siena about this gene, showing that indeed for patients with a mutation in the SLS1 gene, they have an inferior survival, and what is indeed quite important, that they can have also an additional recognized mutation of this area, which can cause, of course, resistance to the pediatric therapy. So, at the moment, however, in the European Human Guidelines, which will be published certainly in 2025, certainly the NGS analysis as well as the detection of particular SLS1 mutation is not yet considered, maybe because only the number of centers that perform this analysis, and we wanted to extend, of course, the data, and the other aspect, of course, to provide the facility with the representation of a higher number of centers. But in the same table, you can see another very important aspect, that at the moment we are following the patients based only on the molecular response. Molecular response is specific time point determines the optimal response to the chemotherapy. There are cases in which indeed there is a high risk of failure, in which cases which are not achieving 30% after 2 months of therapy, or not achieving the complete cytogenetic response after PCR is of 5%, which is our corresponding after 1 year of therapy and so on. And I would say what is really important to point out is that probably certainly there is a validity, the prognostic validity of the molecular analysis. So that confirm, although this is not indeed something linked to the same element. So not the fact that the overall survival is just prognosticated by the molecular response remains absolutely valid. But this is not necessarily means that there will increase number of similarly death. Of course, we are performing this analysis using real-time PCR, and a big effort all over the world has been done just to standardize this analysis in order to have values which are corresponding in each lab, which are involved in this kind of analysis. This has been a huge effort, but fortunately now successful. And this is applied concerning the therapy that we are performing in the personal patients. As you know, as personal therapy, we can use imatinib. In either second line for patients who have not responded well, we can use the second generation either or Bozuti or Konati is not allowed when there is a different mutation. As a third line, we have Bozuti or Konati and more recently, Ashimi President. And the fourth line, we are still to consider the possibility to move the patient to stem cell transplant or investigation of various new drugs, TKIs, which are emerging on the landscape. Second, if we start with second generation, guys, it's also this first time. In general, what we do, unless there is an intolerance or we make changes in therapy, we can move to directly to third line therapy, in particular with Bonatin or modest regulation. So, two main reasons to change the therapy. One is intolerance and the other resistance. And sometimes there is an overlapping between these two needs of changing the therapy, because if you are not relating the therapy, of course, we are assuming less therapy. If you are not taking the drug, there is a resistance to the drug, an obvious resistance. These are data not yet published or comparison in the registry. As you may see, the cumulative incidence of the first time treatment change or the first time therapy chosen is approximately 30% of the patients altogether, but it's particularly similar to what resulted for imatinib, a little bit lower with imatinib, which is more delayed also in the time. And this is probably because whereas, as you will see, the toxicity of imatinib is mainly the diffusion, it's inactive therapy in the disease. For imatinib, there are some accidents, but generally not increasing time. So there is an increasing risk of cardiovascular accident maybe change therapy. And these are the changes due to resistance. As you may see, of course, imatinib is the one who is more frequently changed because of this resistance. And in imatinib, there's approximately the same so the same number of patients who are resistant to imatinib are changed. For intolerance, I would say is interesting because you see that the subgroup is the one who is less tolerated, and you can see that the shape of the curve is different because you can change therapy from one to second, mainly tolerance because of risk of pleural effusion, because you need to do it because of pleural effusion. And you see that this is increasing until 4 years, and then achieves approximately plateau. For development in the market is different. The tolerance is quite immediate, I would say, within the first 3 months of the start of the therapy, and after that, they are changing, but they remain quite a steady level of tolerance. It is another point how many of these patients require in addition, so more than 2 changes of the therapy, and these are approximately 15%, as you may see, and almost equally for all the types that we chosen as first time therapy. So the efficacy is almost the same, and it is a second line therapy of the imatinib. You see the number of studies, the result, and approximately 50% of the cases is successful. And this is another slide showing that indeed the overall survival of those who change therapy with respect to those who didn't change therapy and who supposed to respond well and the regular therapy is the same. This means that indeed the second generation PKIs and the third generation PKI are able to fulfill the risk of dying because of sufficient response. So as I told you, approximately 20% of the patients, 15-20% of the patients require last. Okay, the other direction. So needed to third line therapy from CMR, and the classical third line therapy was presented by Zucchini and Konami, and it is later when the person group has been clearly shown that Konami is a resistance in particular is definitely more effective than Zucchini. But now we have a new layer, machinery, which is was approved as third line therapy, and you may see that the results are very good versus Zucchini for the patients without the 359 mutation. You may see that even the longer follow-up at the moment, which is almost 2 years, I would say this is certainly at the age in terms of molecular response. It's quite ambitious, I would say, for patients only 1% corresponding to what is the genetic response to this amount. This is very well correlated, as a drug, and you see that you are already seen the slides before, that indeed the patients remain more than 50%. This means that indeed the therapy is effective and very well tolerated. The resistance to TKI, I'm going very fast, sorry, is due to the presence of mutations, sometimes we do not mutation. So, mutations however represent approximately 50% of the case failure of the TKI therapy, and this may affect the different domains of the BCR-ABL therapy, but it's important that the presence of mutation in growing phase in which we are not reaching the milestones when there is in particular loss of response, and in case of course of disease progression. The sensitivity of this mutation to different TKIs are quite well established. These are the classical second generation TKIs that we used. You see that the mutations are the sensitivity is different, but polarity and the genetic activity is almost all the single BCR-ABL dividing of the mutations. And I would say, however, there is a group of mutations, like the compound mutations, which are not so frequent but present, which are resistant to both the genetic and to polarity. And this is just to explain a little bit what is going on. What's going on, we have indeed it's a very classic, very flexible clone, which is able to adapt for the situation. There will be mutation. So if there is a small problem with mutation, we do not eradicate. Indeed, there is the possibility of resisting both part of the mutations must be challenged with another TKI. And this is just an example showing that indeed the patient treated with magnet we lose the response. The response of non patients were detected at the beginning, but later on there was a mutation which was resistant to magnet. This patient was moved to the Zagreb, and again didn't respond because of the risk that we resolved the compound mutations. But using more scientific techniques like the AGS, now which allows to go down to less than 1%, and we see that this mutation was already detected that there was a loss of response to magnet therapy, and indeed there was a mistake just to use Al-Madinah because indeed there was a proliferation of this resistant clone, and later on, of course, this clone was able to acquire another compound mutation. So the early detection by AGS of this mutation we can definitely establish a better response of these patients. Finally, I want to state that the double digital digital CCR will become one way of monitoring the disease, particularly for the very low amount of PCR, and we see that these results are introducing the PCR for patients who are negative for the proper digital PCR, high probability will have a successful data. Thank you very much for your attention.
Thank you. The last talk today will be given by my colleague, Dr. Al-Madinah, who will be president hematologist at the Faisal Specialist Hospital in the Center Al-Madinah, with interest in leukemia, and he will be giving a status-sponsored talk about navigating treatment options for benefit patients with relapsed refractory AML, the role of
Thank you for the opportunity. It's very hard to deliver the last talk, but I'll try to make it exciting and especially after also being part of the this session. So these are my disclosures. I would like to begin first with an introduction of how difficult the situation is. As we all know, leukemia is or remains among the top common type of cancers and also remains to be among the leading causes of death. For acute myeloid leukemia, the treatment continues to be a challenge. Only we're able to achieve better outcomes in fit patients who are actually eligible for intensive chemotherapy, especially with the addition of targeted therapy, and also those who can actually be consulted with hematopoietic stem cell transplantation. However, it is challenging for unfit patients because the options are limited for those patients, and even if you attain a remission, it continues to be a challenge to sustain that remission for this group of patients. Those patients, they have important interests when you break the news, the bad news for them having this aggressive disease. They care about quality of life, they care about the values in life, and they require a number of support socially and from the system so they can actually strive in this very challenging journey for them. And researchers and physicians have actually almost came to the same conclusion that disease biology is an entity that remains heterogeneous for AML patients. And it's not only a one state, it's dynamic, it changes over time, and if we are exposed to prior therapy, there will be that effect of selective pressure that will expand further along. So that becomes also a challenging when you determine treatment for any of those patients. And whether those patients are fit or they are unfit, relapse refractory disease continues to carry dismal outcomes. So, can we actually say that we are agreed in how to define patients who are unfit for intensive chemotherapy? This is a suggestion by the Italian group. They put these operational definitions for unfit. So any of them, if they occur, it will qualify as fitness, but we all can come and say, still age is not a defining factor for unfitness. You can see patients who are younger than 75 and they may also unfit. But when it comes to cardiovascular, pulmonary, renal, liver, it's a constellation of multi-system. Based on that, we will agree, and it's a case by case whether those patients are fit or not. And depending on what system or what other system is affected, can they actually get treatment A or treatment B? Looking at this timeline, despite acute myeloid leukemia being one of the most studied cancers, because of so many aspects, the disease can be easily modeled. In addition, bone marrow and blood tissues are readily accessible. Despite all of that, it took us 40 years or more than 4 decades to start using targeted therapy. And hopefully this will continue to change the landscape of the disease. I'm going to just present the case so we can relate to it as we progress in the talk. It's a 75-year-old female who actually had some expected comorbidities for her age. She presented to the emergency department with shortness of breath and some chest pain. It was thought at the beginning that she had had a pulmonary embolism, and then it was noticeable in the exam that she had signs of anemia. And overall, her performance status was believed to be 2. Subsequently, she was found to have leukocytosis with 84% blasts, no evidence of tumor lysis when she presented. However, she was started on routine supportive therapy protocol. Peripheral blood smear on the left side shows predominant blasts, and flow cytometry was in keeping with acute myeloid leukemia. These are pictures of the bone marrow aspiration biopsy showing sheets and sheets of blasts. So, particular analysis for this patient showed normal karyotype and by cytogenetic karyotyping, and by NGS she had 4 mutations. These are the variant frequencies for all of them. Again, she was being unfit because of her history and physical exam, and what were her grade values. For that reason, she was initiated on combination of azacitidine and venetoclax. So what does the addition of venetoclax to azacitidine give to our patient? These are the results of the pivotal trial by that was published in the New England Journal of Medicine in 2020. This actually showed impressive results when it comes to median overall survival with the addition of venetoclax to azacitidine reaching around 20 months. In fact, this everybody would agree was not the beacon of hope for those patients. With a median survival of around 15 months. And even when you go on the right side of the screen, you will see that the remission, because it is pertinent to our talk, the chance of attaining remission was actually higher when we used the combination regimen in around 15% of patients in both arms who were FLT3 mutated, versus if they were only treated with azacitidine. And it was slightly better if it was FLT3 TK. So these results were analyzed subsequently by another group. They actually looked at the results of the phase 1b trial and with the RAA trial. And when they tried to certify those patients who were treated with AZMN using the AMN classification, there wasn't actually much separation between what we call them the favorable and the intermediate risk. But when they use a combination of three mutations, TP53 and FLT3 and RAS mutations, patients who were triple negative, they actually had a longer median overall survival, reaching around 27 months. And if they're triple positive, they will, or just TP53 mutated, they will actually be much worse survival, median overall survival of around 5 months. And as expected, sometimes real-world data can be different than clinical trial, better or worse. Still, these heterogeneous, some other reports we came across, they found that the median overall survival is not as great as was published in the randomized controlled trial when you treat patients with AZMN. And if you take a closer look at the FLT3 mutated patients, you will appreciate that despite there was actually a benefit for the addition of venetoclax to azacitidine, in FLT3 ITD mutated patients, the overall survival is worse than the TKD. So they're the one actually driving the worst outcome on longer follow-up. So this patient received one cycle of AZMN. She was able to achieve remission. However, as we sometimes experience with this regimen, there were multiple delays allowing count recovery, and then a follow-up bone marrow confirmed recurrent AML. I'm not going to spend a lot of time on this, but we all know whether it's a FLT3 receptor, it's a class 3 receptor tyrosine kinase composed of 5 domains, and the first mutation of that receptor that was discovered was the FLT3 ITD, is the commonest one. This was discovered in 1996, and in 2001 they discovered a TKD mutation. Both mutations are activating mutations, so when they happen, that receptor is constantly active. And what can we achieve with patients with FLT3 mutation relapse using conventional chemotherapy? Dismal response and dismal outcomes you can see in these two studies using intensive chemotherapy. So what options do we have for unfit? So those were the fit patients. It would be like our patient. So clinical trial or offering targeted therapy or best support care alone. So if we try to look again at what happens to patients if they develop FLT3 mutation, if you look at the graph on the right side, those who actually clear the mutation, they will definitely do better, almost equivalent to the ones who never had a mutation, but with a FLT3 mutation remaining or acquired, the outcome is actually worse. This is why it's recommended, even at disease relapse, to reassess for mutations including FLT3 acquisition. And gilteritinib is a second generation class 1 FLT3 inhibitors. So it is selective. It can actually work in both types of FLT3 mutation, whether ITD or TK. Gilteritinib was used in this recently published trial, called the Al-Madinah trial. It's a phase 3 trial. This trial has actually so much details in it. I will try to walk you through in the remaining 5 minutes. So they included patients who relapsed with FLT3 ITD mutation, FLT3 ITD or TKD, all inclusive, fit or unfit, had prior transplant or not. So they had to be relapsed or refractory. Majority of them were actually relapsed, around 60%. And they are randomized 2-to-1 to single agent therapy, gilteritinib, versus physician choice of salvage chemotherapy according to fitness. There's always a goal for those patients, especially the ones who haven't had stem cell transplantation or hadn't long time, to take them again to another transplant. And then some of them continued on gilteritinib as a maintenance, which we're not going to focus on this talk about. Very interesting. If you compare this to the graph I showed you a few slides before, the median overall survival was, which was the primary outcome, was actually achieved in single agent treated patients at 9.3 months versus standard of care therapy, and this effect continued on 3 years follow-up between the two arms, even when they censored both arms for having a second hematopoietic stem cell transplantation. It's important to remember, because they were 2-to-1 randomization, to balance the groups. The gilteritinib arm had actually more transplanted patients because the groups were balanced, and we all know how aggressive relapse after transplant can become, and the chance of obtaining remission can be challenging in those patients. So, if you look at another retrospective studies, because one of the presumed issues with this trial was not all patients were on FLT3 inhibitor as part of the first line therapy. The problem is the trial really started and ended just before the approval of FLT3 inhibition, like it was restored. Yet they actually managed to include some patients who actually had prior midostaurin or FLT3 inhibition and relapsed after that. But if you actually look at these retrospective analysis of around 113 patients, even with prior FLT3 inhibition, gilteritinib actually was able to achieve composite complete remission in around 50% of patients, which that number actually was also observed, whether in the pharmacodynamic study, the results study, or the actual Al-Madinah trial, which is impressive. So whether they had or they never had prior TKI, it didn't affect the response to gilteritinib in the worst situation, which is relapse refractory disease. And you can see here, this is just to summarize that the effect is significantly different compared to standard of care chemotherapy. And this is what I was trying to tell you. Even after they censored for stem cell transplantation, the benefit on gilteritinib continued compared to salvage chemotherapy. And whether those patients were actually younger than 65 or older, the reduction of death or survival was maintained across all of these groups, and whether or not those patients received intensive or less intensive chemotherapy as part of their standard of care or salvage chemotherapy. This is also important complications, and it seems to actually help in becoming transfusion independent, achieving close to 2/3 of patients. Not a lot of toxicity when gilteritinib was used. The most common ones would be related to hepatitis, which wasn't like a small proportion, but actually grade 3 and above. But the remaining side effects were very minimal when gilteritinib was actually used, whether it's in the first year or subsequently, especially for the ones who were on maintenance gilteritinib. These are the common side effects that actually happen, which we all are familiar with, and gilteritinib comes in 40 milligram tablet, so dose reduction can actually happen according to adverse reaction. I will show you another slide. But these are the basic lab you would do for patients on gilteritinib. to treatment for a minimum of 6 months, unless there are reasons to stop treatment. So you really have to go for the first 6 cycles, modify as needed, but not too much. Especially, for example, if they develop mild differentiation syndrome, it's actually a good sign, and we manage it the same way like with other targeted therapy. But in case of severe differentiation, despite using steroids, you could hold the medication. And in case of elevated liver enzymes or pancreatitis, you could hold the restart at a lower dose. The most important things that will necessitate stopping the medication is development of breast, which is a serious complication, or there is no response after 6 cycles. So this patient was started on gilteritinib, and she was able to be disease-free for around 15 months before she relapsed again. Remember, the baseline disease had multiple other mutations. Most likely, they were targeted the disease relapse because they were not targeted. So, in conclusion, we all agree that the results of the generalized essentially changed the practice of standard of care, especially for unfit patients. However, FLT3 mutation remains a challenge and it needs to be addressed. More importantly, with this therapy, we need to also be accounted for because that trial was using it as a single therapy. We will be seeing more and more studies combining the treatment with other therapies. So this is an important entity that needs to be addressed. And patients who actually, if you look at the survey analysis we've shown, comparing to high-intensity therapy, treated patients achieve more chance for complete remission and overall survival. And we all need to remember that the toxicity profile is lower than established chemotherapy, and if there is need to discontinue therapy, it has to be examined case by case, and there's always a room for modifying the dose, decreasing the dose, giving the patient a break before complete discontinuation of therapy. Thank you.
Thank you, Dr. Makani. We'll move now to the panel discussion, which will be moderated by my colleague, Dr. Faisal. So I'd like to ask our speakers to come to the podium, please, our first speakers, to take the questions. Thank you.
Thank you, everyone. I'd like to extend my gratitude to everyone and each of you for your commitment and presence at this time, volunteers, attendees, and our guest speaker. I think we have Prof. Katarian with us. Still is not with us. So, any questions from the audience? Yes, still fine.
Those with the CML who will progress to ALL or AML, is there a different measurement? Would you go for transplant? And if you go for transplant, would you keep them on kinase inhibitors, and for how long?
Okay, the number of progression, now there is an increased number of lymphoid progression rather than myelofibrosis concerning CML. However, this is independent from the type of decline that you are using in the diagnosis. What we have heard about with Professor Kantajan about the beautiful results in the therapy of the pH positive ALL, unfortunately, will not apply to the plastic lymphoblast crisis of CML. And this is unfortunately bad thing, as you may see in the last 5 years, the rate of survival of the patients is still low. 2/3 of the patients are still dying. I would say it's, if possible, is better after achieving complete remission to move to the transplant of these patients. For myeloid leukemia, we are still lower in terms of results with respect to what we can have with lymphoid malignancies. But these are quite old data, prospective data. I think that with the new therapy, we can do more and so on. Maybe we can have probably better results, I hope. The problem is that we need also we need to consider that indeed the cases of last crisis are quite few, as you have seen, with a limited number. So we need an international effort to sort out which is the best therapy. Otherwise, in few cases, you cannot throw away the conclusion.
Dr. Benyamin, King Faisal. My question is to Richard Dillon. Currently in the UK, are you waiting for the genomics to be available before starting treatment? If so, what is the turnover timeline? And where do you use the flag data plus go as against 3+7 plus go?
But of course, as you know, with AML, the presentation can sometimes be acute and the patient requires urgent treatment. So where possible, we try to wait at least for a rapid screen, which can be done within 3 days, providing the results with FLT3 and NPM1 IDH mutations, and rapid FISH screening for common fusion genes. The turnaround time for the rest of the genomics, including next generation sequencing, is rather longer, about 2 to 3 weeks. And it's usually, at the present time, it's usually not possible to wait for that length of time, apart from in cases where the disease has a low proliferation, so that would be rather unusual. We're trying to wait for at least the initial genomics, and we're also working to try and improve the turnaround times for the more complex assays based on NGS, so that they will also be available because they're increasingly useful for selecting upfront therapy. And the question about flag IDGO, right now we're working with the National Health Service to have approval to use this. And as I showed in the talk, the effect was greatest in patients with FLT3 and NPM1 mutations. So those patients should clearly also receive a FLT3 inhibitor. We do not yet have our pilot safety data on the flag IDGO midostaurin combination, and we're starting a clinical trial actually this month to establish that.
Thank you all for amazing talks. I have 2 questions to Dr. Giuseppe. So the first one is, the use of TKIs when the patient is intolerant, you tend to give them a reduced dose, and at the same time you get a good result, a good response. But the problem is that we don't see evidence supporting this direction. We keep hearing this from our expert colleague, the CML expert, that you may reduce the dose of continuous as long as the patient is responding.
This is a very, very important question. The results that we have at the moment are mainly with the established dose of the TKI. But already in a very good study performed by the MD Anderson, indeed it has been shown that 50 milligrams first-line therapy with respect to the traditional 100 milligram are even partly better effective.
Recording in progress.
Probably even better than the 100 milligram. So at the moment, I would say for imatinib, the dose is okay for 100 milligram. But for the second generation TKIs, probably what we are doing already in clinical practice, but should be formally demonstrated in clinical investigation, is to start with the dose established, but then once that you achieve a good response, to go down and to halve the dose, in particular maybe from 600 milligram of denoclin to 300 milligram. This will decrease the risk of cardiovascular events later on. And for the other, if you don't want to start with 50 milligram, maybe once that you achieve the 50 milligrams, the NMR or even 1% of the serotonin, which is considered already a safe endpoint, at this point you can increase the dosage to 50 milligram or even lower. There are patients who are continuing their therapy with 20 milligrams. So we need to adapt to the dosage to the patients, the side effects, and to the results also that we want to achieve. But it's not always true attempted to increase the dose to really improve the results in terms of molecular response to the sample. So we must be very careful about this.
My second question is to Dr. Mohammed Al-Munawarah. Is there any role for FLT3 inhibitors in non-AML cases?
Before that, I apologize in order to invite Dr. Faisal to the stage. Dr. Khalil, please, I'm sorry for that. I'm already replacing this one.
That's a good question. Usage, for example, melatonin, because of how does it actually work, you can actually use it to help patients with CK mutation. So there are usages for them in non-AML FLT3, like other AMLs, and also for other types of cancers. According to the only I've seen this with the first generation, because they're actually multi-kinases. They target multiple pathways. But nothing I have used myself. I have used immunostoring patients with CKF, but if this answers your question.
My question is to Prof. Kataja. With the excellent results that you see with the Philadelphia positive plasmid and lymphoma, are you also looking at asciminib and Al-Madinah to replace plasmid? And what about tuzumab, because the disease burden will be higher up front?
So let's start with the inotuzumab. I think adding the inotuzumab is a good idea. I'm worried a little bit about the inotuzumab being occlusive disease and ponatinib liver dysfunction. So far we have not needed to add inotuzumab. As I mentioned in my talk, for the people with the high white cell count, we are seeing relapses, so we're adding back one dose of methotrexate Ara-C, and we have increased intracephalic to proceed. Now, as to the second question, are there better TKIs like asciminib or Al-Madinah? I think we have to wait a little bit, because in the asciminib data and the chronic phase CML, we're starting to see mutations both in the myristoyl side and in the AV kinase domain side. And there was a study of asciminib plus dasatinib in Philadelphia positive ALL, and we're waiting for those results, but I was not impressed about it. So while asciminib may be a very good drug for chronic myeloid leukemia, I don't think it is so for Philadelphia positive ALL. The Al-Madinah data from China in Philadelphia positive ALL looks very good, but we're still waiting for the toxicity data. So far they report that it is a safe drug, but I'd like to have our own ex-China experience about arterial-occlusive events before we can say that safely we want to use Al-Madinah in the frontline CML. I think in Philadelphia positive ALL we're going to do a study of Al-Madinah with blinatumomab, because Al-Madinah is certainly looking so far more effective or as effective as ponatinib and safer than that. So yes to Al-Madinah and blinatumomab, a bit of on hold for asciminib or blinatumomab.
Just another question to Prof. Natalia. The dose-dense mini-microcirrhosis, is it deliverable as outpatient or is it inpatient usually?
So it can be delivered. The first course has to be an inpatient because you started blinatumomab day 5, you have to monitor for cytokine syndrome and neurotoxicity. The second course can be delivered as an outpatient. The whole idea of the dose-dense mini-CVD in Oblina is we would like to see if there is a regimen that we can deliver in 3 to 6 months that could be as effective and could replace the 3 years of intensive chemotherapy. So we're investigating it in the salvage setting. we have moved it to the frontline order setting, and if it works well, we're going to go down the gate. So in Saudi Arabia, if you're interested, you could be a leading group in trying to dose dense municipality and the salvage and in the older patients. And I could give you the whole synopsis, so if you can do it on your own and publish on it, that would be something very innovative.
This is a question for Dr. Khalid. Dr. Khalid, amazing what you showed about the different genomics and the different mutations and even TP53. But the problem is that still clear in the equation. Do you think that should be a yesterday news now, because we have seen progression and development of the new medications in treating CLL?
Sorry, can you repeat the question?
Do you my question is about pleural still in the equation. Do you think it will be just in the past and not moving on?
Yeah, I think the whole story of chemotherapy is going to be dead soon. The only problem is access to these very expensive medications is restricted in many places in the world. And if you look at the data from all of these trials that used chlorambucil and bevacizumab as a comparator, that's a comparator bias, it's a very big bias. But even with that, at 10 years of follow-up, you still get about 30% of patients actually being progression-free. So there's a small subset of patients who actually benefit from that 6 months of therapy.
Thanks for the answer. My question is for Dr. Ihab. What do you think about adding venetoclax to as a strategy in higher risk MDS? Does it apply to those who are transplant eligible?
Thank you for the question. Yes, I agree with you. There are trials of using venetoclax as a strategy in high-risk MDS, especially those with excessive blast. As you are probably aware, now the definitions of high-risk MDS has become a little bit confusing because of the ICC classification and the WHO classification of these high-risk groups. But especially the ones with excessive blast, I would say definitely it is a consideration in young patients who want to take for transplant.
We have two more questions, one for Dr. Ihab and one for Richard. For Dr. Ihab, which is more important for selecting patients for bone transplant in MDS, IPSSR or IPSSM? For Richard, in NPM1 positive MRD AML patients, shall they proceed with urgent bone transplant or receive a bridge with venetoclax? Thank you. We can start with Dr. Ihab and Richard.
Thank you for the question. Patients with MDS who require, what was the question? Bone transplant.
Will you select them based on IPSSR?
IPSS and molecular. Yeah. So the molecular risk stratification is not mature yet. It was first published in 2022, and there are many trials showing its validity. It's valid, but its validity is still being considered. And I would have thought in the future this is the way forward. It will risk stratify for us better the patients with MDS, which ones ought to be transplanted rather than which ones who are considered to be low risk. So I think from a clinical point of view at the moment, most of the data comes from IPSSR. So for the time being, we are sticking with the IPSSR data for consideration of transplant. However, the future is probably with the IPSSM.
Question is a patient with NPM1 AML that's MRD positive after the induction in the blood, so they're high risk and require transplant, whether they should go directly to transplant or have further therapy, for example, venetoclax. So the answer to that is currently unknown. There are no prospective data to inform that. In our protocols, those patients would have had a cycle of intensive salvage therapy with FLAG-IDA before proceeding to transplant in most cases. There is no data to support giving venetoclax azacitidine in that situation, as I'm aware of, and in the cases where I've seen that being done, the response has not been very good. My suggestion would be to give a further cycle of intensive chemotherapy in those cases in the absence of any further data. But I'm sure those data will emerge in due time.
One more question. In your practice, when you will give treatment study, for example, and whom you will give that, do you wait to get them over for the molecular testing in your center?
Yes, so we would wait for the molecular tests that are available quickly. So those would include FLT3, NPM1, and KMT2A whitefish. I would definitely consider giving FLAG-IDA induction to patients with KMT2A fusions, based on the data we presented at ASH, that overall survival was significantly improved, even for those patients that didn't go for transplant. And then, as mentioned in the previous answer, the patients with FLT3 and NPM1 co-mutations also appear to benefit from the intensified induction, but we're currently doing that within the context of a clinical trial protocol.
Thank you, everyone. It's the end of the session. At the end of the day, we'll see you tomorrow, inshallah, at 7:40 again. Again, thanks for staying there.